I'm Dr. Thomas O'Connor, a lifelong powerlifter, board-certified physician, and published academic author. I've taken care of thousands of men on testosterone and steroids, and now I use my media appearances in this YouTube channel to provide education and harm reduction. Subscribe now so I can help you stay strong and healthy. Leave estrogen alone. The benefits of estrogen for men that are on testosterone. This is an interview with a freshly minted testosteronologist, Christopher Bronson, MD. Chris, thank you so much for being here.
Thank you. It's an honor and a privilege.
As everyone knows, I'm now training my testosteronologist army for the world to appropriately care for people, men and women, on androgens. However, for today, we're going to focus solely on men that are taking testosterone, TRT, not steroids, not women, just men, you guys that are on TRT, and we're going to discuss the benefits and understanding the physiology and the adverse effects of blocking estrogen. And this is an internal medicine doctor, Dr. Bronson. Doctor, let's get right into it.
So when you're on testosterone therapy, a lot of people just know that your estrogen levels will go up whenever you give yourself testosterone. And a lot of people have the misconception that your estrogen levels going up is bad. They think it gives you mood lability or instability. They think it makes you more emotional. They think it gives you gynecomastia, which it does. But they think, in other words, they think it's all bad for men to have high estrogen levels. But I will tell you that in the last 15 to especially the last 10 years, we have found that many to maybe most of the benefits, especially the long-term benefits of testosterone therapy, do not come directly from testosterone. They come from estradiol. The biggest benefit that you get from testosterone is, yes, it reduces your fat mass, increases your muscle mass, increases bone density. We know all those things. The key thing about testosterone reducing your fat mass is not only does testosterone reduce your subcutaneous fat, which would be the pinchable fat that you can see externally, the type of fat that you can, remove with liposuction, remove with things like tummy tuck surgeries. Yes, testosterone reduces that. But testosterone, we've known since 2016. There was a paper published in the journal called BMC Medicine in 2016 that showed that not only does testosterone reduce subcutaneous fat, it also reduces something called visceral fat. Visceral fat is the fat that surrounds your internal organs, especially the liver and lines the inner part of the abdomen. And visceral fat is highly, highly inflammatory. Whenever you look at studies that talk about obesity-related illnesses, or the fact that obesity increases your risk for heart disease, obesity increases your risk for cancer, obesity increases your risk for even things like more rapid aging, that is due to visceral fat. It is not due to subcutaneous fat. There are very few things that will reduce visceral fat. We know that possibly statin drugs, for example, can reduce visceral fat. We know these new GLP-1 drugs, Ozempic, Mounjaro, can reduce visceral fat probably. We also know that testosterone reduces visceral fat thanks to the researchers who published this paper. Now, the way that testosterone reduces visceral fat is an effect not of the testosterone itself, but of estradiol. Estradiol is, when your estradiol levels get higher, estradiol inhibits something called lipogenesis inside visceral fat stores. So it makes it much harder to store and build up your visceral fat stores and starts to eliminate those visceral fat stores. And we have studies showing that when men who are on testosterone for over a year, their visceral fat mass decreases, which is a very good thing. Now, we have other studies that show that when you're on testosterone and you're on drugs that prevent the testosterone from being converted to estradiol, right? Because whenever you're on testosterone, some of it gets converted to estradiol. we know that when you're on aromatase inhibitors, for example, those would be drugs that block the enzyme that converts some of the testosterone you give to yourself into estradiol. Patients who are taking those drugs do not get the benefit of reducing their visceral fat mass. We have a lot of evidence that that's
These
the
are
case.
the AIs, right? The aroma. This is.
These are the AIs, aromasin, anastrozole, things like that. In the paper that I'm talking about, they looked at dutasteride and anastrozole and testosterone. So they had 3 groups. They had men taking only testosterone. They had men taking testosterone and dutasteride. They had men taking testosterone and anastrozole. And the men taking testosterone alone and taking testosterone plus dutasteride, they did get a reduction in their visceral fat mass. The patients taking anastrozole and testosterone did not reduce their visceral fat mass. And that is really bad, because if you're going to say that testosterone potentially has life-prolonging effects, okay, which is not proven, I want to make that clear. The primary way that it would do that is by reducing your visceral fat, because visceral fat is what causes the increased risk of chronic disease, more rapid aging, cancer, things like that. So by taking aromatase inhibitors, one of the key problems that you get is you do not reduce your visceral fat mass as much as you would by just leaving your estradiol levels alone. Estradiol, in addition to that, also has beneficial effects on sexual function, right? So we have all kinds of studies and just even clinical experience treating men with testosterone who go on AIs. Oftentimes they'll go on an AI, they'll get erectile dysfunction. Pretty impressive thing to do when your testosterone levels are over 1,000 in many cases, to then get erectile dysfunction. That's a direct effect of estradiol.
A lot of men in the beginning can feel good just because of not necessarily a placebo effect, but just something so novel that they're on these androgens, but they're using these blockers at the same time, not to mention sometimes multiple blockers, right? DHT, all these different SERMs, and it's just too much, and you're not getting that effect, or you're losing the potential better effect, right?
Benefit. Yeah, you're losing the potential benefit. A third problem with blocking your estradiol level that I don't think I've ever heard anybody talk about is there's a paper published in a journal called Redox Biology. It's called Uncovering Sex-Specific Mechanisms of the Action of Testosterone and Redox Balance. So redox balance, to put it very simply, is just how your different cells balance inflammation. It turns out that one of the key reasons why we have an evolutionary mechanism to convert some of our testosterone into estradiol is that testosterone by itself causes a pro-inflammatory state in certain endothelial cells. Those would be cells that line blood vessels, and cardiomyocytes, that would be certain types of heart muscle cells. Okay, so unopposed testosterone at high levels by itself causes inflammation and damage to those cellular structures. The way that God, evolution, has given us to prevent that is convert some of the testosterone to estradiol, and estradiol opposes those cellular actions. So we can say that whenever your testosterone level goes up, you necessarily must have a rise also in your estradiol levels, or you're going to cause damage to your heart and blood vessels.
Now, let me ask you this. Okay, you're on the guy's on testosterone. The memo said that he's going to take 200 a week or 0.5 twice a week or whatever it's going to be, and hopefully less. And he's going to go on the amount he needs, and he's going to have potentially the need for the AI, not to mention other medications that they're going to be started with really no support, just all at once. Now, it is true that men, from the mood issues, let's just go head to toe, the mood issues, it doesn't affect, this is not DHT blockers. We're not going to go into hair loss. So there's the mood in the brain, right, from the head down, the CNS, like the mood from the estrogen there is relevance of the moodiness, and men that they can feel very well, but they're they're moody and they cry easily and they're weepy. I've just never forget guys in the beginning saying, Doc, I can't tell a story without crying, or I go to movies. It's just so, and it's like, that's not a bad thing, brother. But well, Doc, it is, because it's just disturbing to me. And it's, I'm really in touch with my female side now, or I'm just really, it's too much, or they're moody and short. So we don't know really this ratio of testosterone to estrogen. And again, those blockers, guys, I don't like them just as a cookie cutter. So we're going to talk about now how you start testosterone. We're going to say not pellets and not gel and not the oral undecanoate, just injections, microdosing. And how do you look at that? How do we manage that from the get-go? I haven't been on an AI in over 20 years because, 20, 30 years ago, of course, I was on everything. And I just was like, this doesn't make sense. There was no data. I feel like shit. I don't want to rupture my tendons, not to mention, and the heart. So tell us about the treatment side. Let's go into how do you manage that, man? We can't blow off the estrogen. We're not doing that. So go the head, the brain, the gynecomastia, heart, maybe prostate, sex.
So the thing with estradiol is a lot of men just want to focus on what their total absolute number of estradiol is. So if their estradiol when they start, by the way, estradiol is a type of estrogen, so I'm using those terms interchangeably. So they go on testosterone, their testosterone level doubles, triples, quadruples, whatever the case. Let's just say it goes from 300 to 1,000. Okay. They look at their estradiol levels before they start treatment. Let's say it's 30, and then let's say it goes to 50, 60, 70. A lot of men have it in their head that they have to keep their estrogen level under a certain absolute number. But as I was already explaining, the way that you get classically thought to be estrogen-related side effects from testosterone is not due to the absolute number of estradiol itself. It's due to the ratio of estradiol to testosterone. So in other words, when your testosterone level goes up, your estradiol level has to go up. And I just explained with the cellular, damage to blood vessels, things, why we have that mechanism. But if you get side effects like gynecomastia, that is due to an elevated estrogen to testosterone ratio. At least that's as far as we can determine, that's what causes it. It's not due to your estradiol level, strictly speaking, going from 20 to 40 or whatever it is. It's due to how much estrogen you have relative to testosterone and how much you get stimulation on the breast tissue. So think of gynecomastia as a side effect of testosterone. Think of some of those mood effects. It's a side effect of testosterone. Don't think that it's estrogen per se. So anytime you get a side effect from a drug, the answer is not to give you the primary ideal answer is not to give yourself a drug to reduce the side effects. Ideally, you want to just tackle the problem at the root cause. The number one way to handle gynecomastia is you can just reduce the dose, even a little bit. It does not have to be a significant dose reduction. And the reason for that is it's an enzymatic process. So your body and your cells take some of the testosterone through a protein called an enzyme and convert it to other metabolites, one of them being estradiol. It's not like you get a 50% greater risk or 50% more gynecomastia if your estrogen goes from 20 to 40. That's not how it works. It's always in balance. It's always regulated with testosterone. So the key thing you want to do whenever you get excessively moody after you start testosterone, or whenever you get gynecomastia, whatever the case may be, you just need to lower your dose.
Let's talk about microdosing.
You don't want it, you can lower your dose, or you can do what's called microdosing. Microdosing would be, a lot of people refer to microdosing as taking testosterone every day. So splitting what would be like a once weekly or twice weekly dose up. Let's say you're on, I'm just going to throw a number out there. Let's say you're on 200 milligrams of testosterone cypionate weekly. So every 7 days. What you would do instead is a microdose compared to weekly would be 100 milligrams every 4 days or something like that. Or, you can split it up into daily doses.
And
right?
then what? And
So that microdosing has been shown to reduce what I'm talking about, what's called the excursions in the estrogen to testosterone ratio. That will make it so your estrogen and testosterone levels just don't go violently up and then roller coaster. If you're giving yourself smaller doses at more frequent intervals, that will oftentimes improve your symptoms.
And let's
too.
talk about, doctor, the IM intermuscular versus the SubQ, because you have such a great handle on that.
Yeah, sure. So when you give yourself testosterone into a muscle intramuscularly, the problem with doing that, and it's a great way to get testosterone. So, if you're doing fine with the IM and you've been doing it for years, I'm not saying you need to necessarily change anything. But the problem with the intramuscular is the droplet forms in the muscle and then it gets absorbed slowly over time into the circulation. Now, the issue with that is the rate and degree of absorption is highly dependent on blood flow to that muscle. So as you can imagine, if you're, let's say you give it into your glutes and then you go squat or something like that. Yeah, that's going to have an effect on the rate of absorption such that you may get different absorptions depending on what you do
all over the
and
body,
how you
different
exercise.
muscles. It's unbelievably true.
Exactly. And in contrast, that when you give it to yourself subcutaneously, one benefit is, number one, you get better absorption. So you do not need to use as high of a dose. You only need about 15% of your IM dose given SubQ. That's one benefit. Another benefit is because the oil droplet forms in the subcutaneous fat, it gets absorbed in a much more predictable manner because some of it goes into the circulation like it would in the muscle, but not in a blood flow dependent way. And also, a lot of it goes into the lymphatic system, and that gives you a more stable, steady release. And there are studies showing that going from IM dosing to SubQ dosing can reduce side effects, and you can use a lower dose. And yes, you can microdose.
It's really
so.
This is the take-home message. Is I didn't realize until we started working and talking about this in our Ask the Doc meetings with all the affiliates we have, that the component of via subcutaneous, not just because there's less blood flow in the subcutaneous compartment versus a muscle, and of course the muscle's contracting, and if there's different muscle areas in the body, and if you're kneading it, if you're sitting on it, if you're walking, if you're training, that's amazing. Every guy who's on testosterone or steroids understands this to the variability, right? And it's all man per man fingerprint. However, when you're injecting subcutaneously, beyond the fact that I don't like the nodules, especially around the belly, because even insulin users who have to use the belly, it just gets gnarly and beat up. You ever see the type 1 diabetic who has to inject and check, on the top of on the forearms? Their skin just looks gnarly after years, but they're a type 1 diabetic. So that's the old school stuff before the special technology. But when you look at in the lymphatics, now, this is oils and oils, right? That's what you have. And with testosterone undecanate, where it runs through the lymphatics, right? Where it runs through, right? It doesn't go, this is where it's like, how does you take this oral testosterone derivative drug and it doesn't, it's not like Dianabol, right? So it's not a 17 alpha alkylated oral steroid because it's not, number one. And it runs through not the GI tract. This is what people need to understand this. It runs through lymphatics. And that's an oral. That's why you need to take it with fatty food. But it's annoying, right? You twice a day. That's a limitation on oral undecanate. Okay, to get back to the injections, when you start seeing the patients, and I've seen so many that there's so much variability. But patients will we love that Zyosted, we love that injector. Especially for lazy guys like me, after 35 years of injecting, you put it in SubQ in the upper thigh or something. You just don't have to do it SubQ. You can do SubQ in different parts of the body. Matter of fact, if you do it in the rear, it's going to be SubQ with that little injector. Because I got this much fat on the top of my on my glutes, at this point. So that's what people don't understand. Right. But if you do it and you're going to put up with the enanthate, which you can do through the injector, Zyosted, or just get enanthate and use those 27 or 29 or 30 gauge needles. If you could pack, you can get those. It's just a lot of work. So a lot of people don't want to do that. You don't have to do it. In the end of the day, when you're looking at testosterone troughs, typically when you're doing it 5 to 7 days, that's the common bear. Everyone, after the newbies start and they're doing the daily dosing or every other day, even days or odd days, doc, or Monday, Wednesday, and Friday, 2, 3 years, 5 years later, 10 years later, you ain't going to do it. You're going to be doing it every Sunday morning because you'll remember. And it goes up and down, but most men feel well. But the estrogen, looking at not total, but looking at the ultra sensitive estradiol, liquid chromatography, mass spectroscopy. We have labs out there with health labs. You can get it on the app. You can get it outside the app, up here in the description and in the link tree. But you want to understand, are you right after the injection, Dr. Bronson, right? Are you going up? Are you peaked? Are you going down? Is it 2 weeks later, a week later, 2 days? Are you on Masteron, Primo, Proviron? Are you on Decadurabolin, NPP, Tren? What other drugs are you on? They're going to affect, like you said, the sex hormone binding globulin and the estrogen and the carriers. It's so dynamic. But estrogen is what you've taught me from the data. I wanted to get out. That the mood effects. And again, if you are moody, you have to look at not estrogen, but testosterone comes together with testosterone, DHT conversion, and estradiol conversion, right? There's different, and you have to think of the head down, the brain function. It has to work for you. Some men feel terrific and feel motivated like I do, or they feel anxious. And they can't even take. I have some men, very rare, that cannot even take testosterone because they end up in the emergency room with panic attacks. They just have too much general anxiety. Sure. And I don't care if it's the testosterone, the DHT, or the estrogen. We've tried every permutation and combination with AIs and SERMs. And that's the rate limiting step. And he's just cries to me and says, "Doctor, I got to see you later. I just can't take any gels, injections, pellets." It's very rare, but it's an extreme case that will manifest commonly with so many people. A little anxiety, or maybe they're bipolarish, or they're up. It's just stimulating some underlying mood disorder they have that we could have, or a personality characteristic that is now on androgen too much, or the estrogen. Is it helpful? Is it not? Can you live on a blocker? I don't like to live on those blockers because they're adverse for the brain, the sex, and for the tendons and the heart.
Yeah. And now we know that if you're on those blockers long term, one of the key benefits of testosterone therapy, reducing visceral fat mass, you don't get that benefit. At least you don't get that benefit to the same degree as people who just leave their estrogen alone. Whatever your testosterone level is, your estradiol level needs to be allowed to rise in tandem with your testosterone level.
So that's it. And there's more. We just did the head, and we did the heart, cardiac function, and part of the sex. But for estrogen and the prostate, BPH, and also understanding the aspects of malignancy is a whole other topic that I think I'll have to get a urologist for, doctor, because we're just internal medicine doctors. But thank you so much, Dr. Bronson. I want everyone, we're going to pop up some B-roll here to find Dr. Bronson. He's available in how many states are you able to see patients with telemedicine and non-telemedicine?
Yeah, so right now it's primarily 4 states, South Dakota, Iowa, Minnesota, and Florida. We're opening a clinic in Florida at the end of this summer. My website is B3 Clinic. That's B3clinic.com. So we have just a patient interest form up there that you can fill out if you're someone in Florida or any of the other states I mentioned, and fill it out, get in touch with us. We do the anabolic recovery medicine. So we take care of men on androgens. But we also, do testosterone therapy, and it's very high level. As you can tell, I'm very research based, the up-to-date research. That's why I don't like aromatase inhibitors, because this is all up-to-date research stuff. Is not like stuff that we've known about for decades. So,
But you will,
we have a lot of slots
right?
open
And
in
he's
Florida
growing,
right now.
and he's a testosteronologist, licensed and trained by me, and that's how we're growing scaling this movement to protect men and women all over the world, so I could really impart what I've learned and pass along to brilliant doctors and nurse practitioners, that we have working with us right now. So, but you will use, guys, we don't globalize it. We will give an AI to you. We just don't jump on we just don't start with the McDonald's medicine AI with half the milligram twice. It's just not like that. It's last resort. And we do use serums, tamoxifen, potentially raloxifene. We don't need to talk about it. We use it for gynecomastia, in a limited sense, because again, the side effect profile with venous thromboembolism and even rare issues with the eyes and ocular, you can see it. I've seen everything at this stage of my game, but you want to keep things clean. And you're on testosterone, enjoy testosterone, microdose it. And if you have anxiety and all these other issues, work around it with the doses and with your healthcare providers with what you have. Because you're putting yourself on testosterone. And if you're going to do steroids and you're young and you're doing it for a specific purpose, I have a lot of respect for I just want to protect with the harm reduction. But that it's going to be dose dependent. So, but thank you so much, everyone. Right. Let's get a lot of comments on this, because again, on this movement that I have in this YouTube channel, it's really the comments from you that men will come and women will come to read and to understand the truth and responding to a certain topic. So thank you so much, Dr. Bronson. We will see you again. Thank you so much.